Recording in progress.
All right. So, as I was saying before, today we're going to start in Chapter 11, which is Airway Management. Um, this is a pretty long one, 133 slides. There's a lot of them that we won't cover as well because there's a lot of things in here that we'll cover during the boot camp, as well as there's some things in here that there's some things in this chapter that are ALS, or I'm sorry, that are paramedic skills. We'll bump on them a little bit just so you're familiar with the process, but we're not going to strain ourselves on the subjects. Okay. All right. So as you can see, the National EMS Education Standard Competencies. There's some more. This is going to go over some anatomy as well. So we're not going to, like I said, we're not going to kill ourselves on it today. We're going to try and make this very simple. Because it's still going to be long no matter what. Did I miss something? Nope, I did not. All right, so as we talked before, the most important steps in caring for your patient is obtaining and maintaining that patent airway and ensuring that the patient is breathing adequately. Adequately, remember? Oxygen reaches the body tissues and cells through breathing and circulation, right? So during inhalation, oxygen moves from the atmosphere into our lungs. Carbon dioxide leaves the body during exhalation, and the primary objective of emergency care is to ensure optimal ventilation. We're trying to ensure that all of that works correctly. Okay. Basic airway management skills tend to be taken for granted. So they're among the most crucial skills that we can have as EMS provider. Okay, and we need to learn them and those skills, and we constantly have to hone those skills as well. So just make sure that you're on your game when you're talking about these. All right, so anatomy review. The respiratory system it consists of all the structures of the body that make up the airway and help us to breathe. Uh, the airway is divided into the upper and lower airways. Structures that help us breathe are going to include the diaphragm, all right, the diaphragm, muscles in the chest wall, accessory muscles of breathing, like we talked about before, nerves from the brain and spinal cord. We've talked about all those nerves. Ventilation is the exchange of air between the lungs and the environment. Okay? The ventilation is the exchange of air between the lungs and then the environment as it comes out. Okay? Or in and out. The diaphragm and muscles of the chest wall are responsible for the regular rise and fall. Has anybody ever seen the experiment when you were a kid where somebody took a bottle, and it looks like I'm trying to keep from showing a label. So somebody took a water bottle, and they would take the water bottle and then cut the bottom off of it, put a balloon in there, and then they would take a balloon and put it over the bottom that they cut. And when they would pull it, it would inflate, and when they would push it, it would deflate. So that's part of that system there. Okay. Y'all are seeing the slides, aren't you? It is some FCHS stuff. Okay. All right. I wasn't sure. It's got an odd little symbol on the deal here. So that's what that was kind of displaying, was how the diaphragm works. Whenever you pulled on that balloon, the diaphragm comes down and causes the lungs to inflate. Whenever you pushed on the balloon or you released it, it pushed the air out of the balloon. You know, man, FCHS, we were, Forest County, we were a little, we had to have those visuals. Had to have those visuals. But we also had pigs and cows and everything else that we could use as we could use pig lungs and everything else. We just had it right there. Shoot, the football field, we had them in the building sometimes. All right, so there's a figure. So we've talked about before about the surfactant that gets on there, or when we talked about atelecticus. Okay. So just what I was talking about. Oh my goodness. All right. Let me figure this out here. So this area right here is where on the alveoli. So this is where the surfactant would be. Okay, and that surfactant is what allows the alveoli to move freely. So whenever it inflates, it does. There's no friction or anything like that. It kind of lubes it up. Well, what happens is whenever you have different types of issues or illnesses, that surfactant dries up, and when that happens, then you have an issue with that, and then it grows into other things. It grows into other issues such as atelecticus at that point. As you can see here, also the use the laser pointer. As you can see here, also, this is where we were talking about that the exchange happens, that gas exchange. Okay. Diaphragm right here. So this is actually a little bit different view, but usually which side, which main stem, or which sorry, I'm losing my head real quick. Which main bronchus right here is going to be bigger, the right side or the left side? Does anybody remember? The right, that's correct. So, whenever you intubate somebody, we'll talk about this paramedic skill. Whenever you intubate somebody, change my pen. Okay. It's going to come in, that tube's going to come in here, right? And then it's going to stay in the throat. All right, so ideally, you want it to stop around this area, right? Or up here, or whatever. You want it to stop. Actually, you want it to stop just past the vocal cords. What happens sometimes is it'll come down, and then it'll get into that right main stem. And at that point, you're not feeding any oxygen to this side. You're only feeding oxygen to this side. And that's going to create issues. So at that point, you just have to back out and back it up a little bit. But you'll see people that they'll have there's a measurement. There's a measurement on the ET tube, and that measurement on that tube, it reads down the side of it, and you have to put that in your documentation. What you know at the teeth. So if you got 23 at the teeth, you need to put that. So the thing is, if you got that thing hilted, where that that round piece that's up at the top is all the way touching the teeth, you're probably right main stemming it. You're going to be main stemming it at that point probably, and that's not a good thing. All right, so the upper airway, the larynx is considered the dividing the dividing line between the upper and lower airways. Um, Major functions of the upper airway are to warm, filter, and humidify air brought into the body. The pharynx is composed of the nasopharynx, the oropharynx, and the laryngopharynx. The laryngopharynx is the lowest portion of the pharynx. All right, there's a good cutaway there. So the oral cavity, that's A. And if you ever get an opportunity to, if you ever get an opportunity to, right here, if you look right here, if you want to know how hard that person is going to be or that individual is going to be to intubate, you can look right here. And does anybody know what we call that score? We give them a certain score by looking in their mouth right here. Does anybody remember what that's called, or does anybody know what that's called by any chance? So what it's called is the Mallampati score. So the Mallampati score, you'll see the uvula. You'll see the uvula here. And then from there, you'll see the top of the tongue. The tongue there is swished to the side, but you'll see the top of the tongue right here. And what you do is you see where that tongue, how far that tongue is from that uvula, or if it's hiding some of the uvula or what, and that'll let you know the Mallampati score of that patient. This patient here has a Mallampati score of 1, which is great. That's a great patient. Your heavier set patients are generally thought to be anterior, which means that all of their stuff is going to be towards what? Their larynx and everything else, their cords are going to be towards what if they're anterior? Anterior. Does anybody remember that? Towards the front. That's right. So it's going to be towards the front. And then you know that you're going to have to do what's called a burp maneuver. Okay? All right, so the nasopharynx. Union of the facial bones forms the nasopharynx, all up in this area here. Um, and it's divided by the septum. The nasopharynx is lined with ciliated mucosal membrane. So cilia, y'all remember what that is? The little hairs. The cilia helps move contaminants out of the body. From lateral walls of the nose, 3 bony shelves called the turbinates extend into the nasal passageway. Okay. Sinuses are cavities formed by the cranial bones. You'll notice they're in this area. If you've ever had sinus problems, you can feel them. You feel pressure in them. All right. Fractures. I'm sorry. Fractures of certain sinus bones can cause leakage of CSF, cerebral spinal fluid. What color is CSF? What colors, or what are the main colors of CSF? Does anybody know? Clear, or it has a what color tinge? to it as well. Yep. So tinted yellow, yep, a tinge of yellow in there. All right, so what tests do we do on trauma patients or anybody suspected? If we see something running out of their nose, what test do we do? A halo test. That's right. What are we looking for on a halo test? What are we looking for? Yep, you're looking around a yellow ring that's going to be around the blood spot, right? Looking for that yellow ring. Cool. Kind of like oil and water. Yep. Kind of like. All right. Moving on. The oropharynx. The oropharynx is a part of the throat found at the posterior, all the way back there, of the oral cavity. The epiglottis is a leaf-shaped. It's like a cartilage type flap. It's located at the base of the tongue and above the larynx. If that gets, sometimes if you have a floppy epiglottis, it's hard to lift it up, and when you're trying to intubate, it's hard to lift that thing up and move in there. And other things is that there's a certain way the two blades that you have as a paramedic is a Mac blade and a Miller blade. The Miller blade is the straight blade, and then the Mac blade is a curved blade. Well, the reason the reason why they're the shapes that they are is that curved blade, that Miller or that Mac blade, it's supposed to take where the epiglottis is. Okay, so you looking down, the epiglottis is right here. Here's the roof, right? The roof of the throat. Here's the epiglottis over the hole. So what that blade does, it comes in here, it gets right in this nook, and whenever it gets into the nook, it pushes it, and it lifts that epiglottis up. Whenever it lifts the epiglottis up, at that point, you can see the cords, and then you go in. The Miller blade, the Miller blade is supposed to be straight, so you go in, and then you will grab the epiglottis and you lift it up manually like this, and then you go in, okay, to get it in there. So that's how a Mac and Miller blade works. Just some gee whiz information for you, and it kind of helps you know. Here's the problem with tracheal intubation to some extent. Okay, so you get in there and you start messing around too much. Okay, with this epiglottis and not doing right and everything else, the body has a way of protecting itself, and those cords that you see will shut up. They will shut. Okay, and when they shut, you can't get anything in there at that point, and you have to pump oxygen, pump oxygen, pump oxygen. So the cords shut. What if you start to do that? It can actually cause them to shut. Something else that it does, if you mess with that epiglottis too much, one of the main things that it'll do, if you mess with the epiglottis, it'll cause a vagal. It causes a vagal reaction, which will cause the blood pressure to drop, them to pass out, and everything else. Okay, it'll cause a vagal reaction if you start messing around in there too much. Now, so there is one main issue whenever you have those cords shut. There's an injury that you can have that can actually cause those cords to shut. Okay, and what type of patients would those be that causes those cords to shut? And they will shut up to protect the airway. So there's a certain injurious event that can happen to you that will cause those cords to shut. Does anybody remember that? Just think, it's drowning. Exactly right. Good job. Good job, drowning. So when you drown, those cords will shut, and at that point, it's protecting the airway, and you can't get in. How do you overcome that? And what is that called? Bonus points, what is that called? Bonus points in the form of telling you awesome job. Whenever those cords shut up, that's called something. What is it called? Come on, I have faith in every one of you. Bing, bing, bing. Okay, so it's going to be called laryngospasms. Does that ring a bell to anybody? Laryngospasm. All right. So if you remember it, if you now remember, oh yeah, I remember that shit now. So in a laryngospasm, there is a way to overcome it. What is the simplest way to overcome a laryngospasm? What is a way that, as an AMT or an EMT, that you can overcome a laryngospasm? Does anybody remember that by any chance? No. There's a way. You don't have to worry. Crike pressure is going to be for a hard intubation, not so much because of a laryngospasm. So what you can do is hyperventilate that patient and oxygen. Well, the jaw thrust, all the jaw thrust is for is to open the airway. It doesn't do anything for the cords. Good guess though. So all you do is you 100% oxygen and hyperventilate that patient, and at some point it should show, hey, I'm not. The body or the brain starts getting all that oxygen, and it says, oh, well, there's nothing trying to interfere. There's only oxygen trying to get into my lungs, so now I can relax, and it'll open up. Okay? Okay, some of the stuff we'll talk about right here. What type of procedure is done right in this area right here that we may have to use this cricoid thyroid membrane? Does anybody remember that? There's a procedure, an airway procedure that we may use for that. Trait. Yep. Cricothyroidotomy. Yep. Surgical cric. That's correct. All right. The lower airway. The function of the lower airway is to exchange oxygen and carbon dioxide, right? External boundaries are the fourth cervical vertebra and the xiphoid process. Okay? The trachea or the windpipe is the conduit for air entry into the lungs. When the trachea reaches the thoracic cavity, it divides at the level of the carina. Okay, and that's where it comes apart right here. If you main stem doing a tube, if you main stem that patient, it's going to sit down on this side, right? If it sits down on this side, then you're not feeding air into this side. So you got to back up. Back it up. All right, so All lung tissue is covered with a thin, slippery membrane called the visceral pleura. Okay, visceral pleura. The parietal pleura lines the inside of the thoracic cavity. Can it blow the lung? Mm, yeah, you can. You can. If it starts to trap air, then you can. Most of the time, you're sitting there going, and they'll get harder. They'll get a little bit harder to do, or their capnography will be off. And we'll talk about capnography later on tonight, and you'll see that. You'll be like, "Oh, I screwed that up," and you'll back it up, and then you're okay. All right. So on entering the lungs, each bronchus divides into increasingly smaller bronchi, which subdivide into bronchioles. So bronchus, I, and eoles. Okay. Bronchioles are thin, hollow tubes made of smooth muscle, and then the smaller bronchioles branch into alveolar ducts or alveolar ducts, and they end into the alveolar sacs. The alveoli serve as the grapes serve as the functional site for exchange of oxygen and carbon dioxide, as y'all very well know. All right, so oxygen diffuses through the lining of the alveoli and into the pulmonary capillaries, and then surfactant lines that alveoli. We talked about that. So decrease it, crud. That surfactant, like we said earlier, it decreases the surface tension and helps keep the alveoli expanded, helps keep it open. If the amount of surfactant is inadequate or the alveoli are not inflated, the alveoli collapses, which results in atelectasis. It's like we talked about. So between the lungs is a space called the mediastinum. So media meaning middle, right? It's surrounded by a tough connective tissue. Uh, in that area, it's going to contain the heart, the great vessels, the esophagus, the trachea, the major bronchi, and many nerves. So in the middle there, you got the mediastinum, which is the house of the heart. It's the heart's house. It's the mediastinum. Um, the phrenic nerve innervates the diaphragmatic muscle, allowing it to contract. That's what the phrenic nerve is going to do for the diaphragm. So let's get into the physiology of breathing. So the physiology of breathing, the respiratory and cardiovascular systems, they work together. It ensures a constant supply of oxygen and nutrients in every cell in the body. It ensures also that carbon dioxide and waste products are moved from every cell in the body. And then it's important to understand how the processes of breathing and circulation are connected. The heart pumps into the tissues of the body through a series of arteries and veins, right? And then arteries carry oxygenated blood away from the heart and branch into arterioles and capillaries, okay? And then oxygen and nutrients leave the capillaries and enter the cells. Waste products at that point diffuse from the cells back into the blood of the capillaries. And then all veins except the pulmonary vein carry deoxygenated blood to the heart. All veins except the pulmonary vein carry deoxygenated blood to the heart. At that point, deoxygenated blood enters the right side of the heart through the right atrium. Deoxygenated blood, right side of the heart. through the right atrium. When one system is compromised, oxygen delivery is not effective and cellular death could result shortly thereafter. So there's a good little picture there. Every cell in the body needs a constant supply of oxygen to survive. Sufficient levels of external ventilation and perfusion are required to deliver adequate amounts of oxygen to the tissues of the body. So as you can see there, that this is the main number that I always ask people to pay attention to. Right here. 4 to 6 minutes. All right. After 4 to 6 minutes, it's almost guaranteed that you're going to have irreversible brain damage after 4 to 6 minutes. Oh, told you. This thing's trying to be wonky on me. I'm going to take a guess that my son's downstairs using up all the bandwidth. I told him not to. Kids. All right, so ventilation. Let's talk about that. So ventilation is the process of moving air into and out of the lungs. It's necessary for oxygenation and respiration. It's essential for life, and the high priority in treating any patient. If a patient is not breathing adequately, you immediately have to intervene to ensure adequate ventilation. Ventilation is the mechanical part of breathing. Okay, so that's the pumping air. That's the part where you got to get a deep BVM and you got to work. You got to be that mechanical portion. Inhalation is active. It's active. The active muscular part of breathing. So air enters the body through the mouth and the nose and moves to the trachea. The diaphragm and intercostal muscles contract, and maximum inspiration is going to occur when the diaphragm and intercostal muscles are contracted and the lungs fill with air. So that pull down, that balloon pull down, the lungs have no muscle tissue and they cannot move on their own. Okay? The ability of the lungs to function properly is dependent on the movement of the chest wall, and supporting structures. So the thorax, the thoracic cage, the diaphragm, and accessory muscles was going to help that breathing. The diaphragm it's a specialized skeletal muscle. It functions as both a voluntary and involuntary muscle. It also performs an automatic function in breathing. It's what helps us breathe. We have any questions so far? Clear as mud. All right, so let's get into partial pressure. So partial pressure, it describes the amount of gas in air or dissolved in fluid, such as blood. It's measured in millimeters of mercury, and the body attempts to equalize the partial pressure, which results in oxygen diffusion across the membrane into the blood. Okay? Atmospheric pressure is normally higher than the air pressure within the thorax. Okay? and for good reason. You don't want to. It keeps it from overinflating, right? During inhalation, a slight vacuum is created. Gases such as oxygen will move from the area of higher pressure to an area of lower pressure until the pressures are equal. The entire process of inspiration is focused on delivering oxygen to the alveoli. It's the whole point of it. So variations in tidal volume, respiratory rate will both affect the minute volume also. Exhalation. So it does not require muscular effort. It's a passive process. So the Herring-Brewer effect is the feedback loop. It's a combination of mechanical and neural control. So relaxation of the diaphragm and intercostal muscles increases the intrapulmonary pressure. When the size of the thoracic cage decreases, air in the lung is compressed, okay, into a smaller space, increasing the air pressure, okay. Maximum expiration occurs when the diaphragm and intercostal muscles relax. Air is exhaled forcefully as opposed to the normal passive process. Clearing and maintaining that open airway is crucial. So maintain the airway also means keeping the airway patent. That's what patent airway means. Air may also pass into the chest cavity through an abnormal opening in the throat or chest wall as a result of trauma. All right, when that happens, what happens? Whenever it gets into the chest cavity, what happens at that point? When it's not in the lungs, but it's in the chest cavity, that is a certain event. Does anybody remember? Pneumothorax. That's right. Leanne's killing it, y'all. Mary Poppins, y'all. For any Marvel fans out there. Gotta give me some more water before I thirst to death. All right, so regulation and ventilation. The body's need for oxygen is dynamic. Regulation of ventilation involves a complex series of receptors and feedback loops. For most people, the drive to breathe is based on pH changes. Remember the carbonic acid changes and things like that, right? Or carbonic acid buildup and all that. That's going to create that pH change, and in the blood and in the CSF as well. In healthy people, when the oxygen level rises, the respiratory center suspends respiration until a rising carbon dioxide level stimulates the respiratory center. And that's going to be in a healthy person, right? Oxygenation. So the process of loading oxygen molecules onto hemoglobin molecules. How many? 4, right? In the bloodstream. Part of that oxygenation process. Adequate oxygenation is required for internal respiration to take place. At high altitudes, atmospheric pressure makes it difficult to bring sufficient amounts of oxygen into the body. Something to think about. That's why it's harder to breathe at higher altitudes. I remember when we were in Afghanistan, whenever I did my PT test or whenever I did my PT runs and everything else, when I first got there, I was like, holy cow, I can barely breathe. I was like, I can barely breathe. I run, back then I ran all the time. I was like, I don't know why this is such a problem. And then we had I practiced. I had a marathon that we were going to do, or not a marathon. I'm sorry, it was a 10. It was a 10K. So we did a 10K while we were there, and I just remember we had practiced so much and we ran it. Did pretty good. It wasn't too bad, but you could see the people that had just arrived at this base. They were out there and they were trying to run that 10K because a lot of them run 10Ks back at home, and they're running this 10K, and man, they were falling out all over the place. And it's because of altitude. The partial pressure of oxygen was significantly different, so there you weren't able to get as much oxygen into your body like you want to effectively. Now, what was crazy is when I got back home. At that point, I could go running, and I was perfectly fine. I mean, I could run forever, and it's because I had built my body to sustain that oxygen, or to better utilize the oxygen at the higher altitude. That now, when I got home, it was super efficient. Now I can't run worth a darn. I did a 3 miler this morning, and I'm pretty sure I should have clocked in at some point for work because it took me a long time. So, anybody see that? I just dumped water in my lap. That's great. All right. About 8 minutes, I'll go and get a towel. All right. All right. So respiration, uh, continued, or respiration. So metabolism. That's cellular respiration. Cells take energy from nutrients from a series of chemical processes for metabolism, and then during metabolism, each cell combines nutrients and oxygen and produces energy and waste products. Okay, um, each cell in the body requires a continuous supply of oxygen and a regular means of disposing of waste. Respiration is the process of exchanging oxygen and carbon dioxide, and it occurs by diffusion. All right, so external respiration. It's a process of breathing fresh air into the respiratory system, exchanging oxygen and carbon dioxide between the alveoli and the blood in the pulmonary capillaries. It's adequate ventilation does not guarantee external respiration. I repeat, adequate ventilation is not going to guarantee external respiration. Okay. Um, Hemoglobin molecules pick up fresh oxygen as it crosses the alveoli membrane, or alveolar membrane, and it transports it back to the left side of the heart. Left side of the heart. Yeah, right. The child is downstairs, but this one right here dumped water on himself. All right, so internal respiration. It's the exchange of oxygen and carbon dioxide between the systemic circulatory system and the cells of the body. As the oxygen blood travels through the arteries and capillaries, the oxygen passes from the blood in the capillaries to tissue cells. In the presence of oxygen, the mitochondria, if you remember that term, uh, the mitochondria of the cell convert glucose into energy using a process known as aerobic metabolism. Energy in the form of ATP, I know y'all remember that, is produced through what cycle? We're seeing it again. The Krebs cycle. And then oxidative phosphorylation. Bringing the Krebs cycle back up again. Anaerobic metabolism, it cannot meet the metabolic demands of the cell. Glycolysis results in less ATP production, and adequate levels of perfusion and external ventilation must be present for aerobic internal respiration. The anaerobic metabolism occurs when oxygen is not present. Anaerobic. An usually means what? Lacking, missing, not there, right? Anaerobic metabolism is when oxygen is not present. Understanding the process of ventilation, oxygenation, and respiration is an important concept for us to know. So you may need to go back and read over it, trying to get the pictures, YouTube the mess out of it, and rock it like I know you can. So the goal of all of this is to deliver an adequate supply of oxygen to the cells of the body. Simple. So neural control. Let's chat. Neural control is neural control of breathing originates in the brain and the brain stem. Primary control comes from the medulla oblongata. Sorry, I had to. And pons. The medullary respiratory centers control the rate, depth, and the rhythm of breathing in a negative feedback interaction with the pons. The apneustic center of the pons is the secondary control center if the medulla fails to initiate respiration. Pneumotaxic center, the pneumotaxic center has an inhibitory influence on inspiration. Respiratory rate results in the interaction between apneustic and pneumotaxic centers. Okay? And it decreases its influence. So let's talk about chemical stimuli now, and chemoreceptors. The body has many receptors that monitor variables and provide feedback to the respiratory centers, and that modifies. I'm sorry, and those centers modify respiratory rate and depth. The chemoreceptors have important effects on respiratory rate and depth. Those chemoreceptors do. Chemoreceptors constantly monitor the chemical composition of body fluids, and chemoreceptors that measure the amount of carbon dioxide in arterial blood are located in the carotid bodies and the aortic arch. All right, so we know where the carotid bodies and the aortic arch are, right? We should. Central chemoreceptors, which constantly monitor the pH of the CSF, are located adjacent to the respiratory centers in the medulla. An increase in the acidity of CSF triggers the central chemoreceptors to increase the rate and depth of respirations. Chemoreceptors located in the aortic arch and carotid bodies also respond to decreases in partial pressure of oxygen, or PaO2. And that's the backup to the primary control of ventilation. Okay. When serum carbon dioxide or hydrogen ion levels increase, chemoreceptors stimulate the dorsal and ventral respiratory groups in the medulla to increase the respiratory rate. All right, let's do this. Let's take a 10-minute break. Dude, I can't see nothing. Does anybody have any questions so far? Bueller? I do have one question. When you said adequate ventilation does not guarantee. Okay. Okay. Sorry. Let me know if I'm going too fast and I'll slow down. Let me get back to that slide. So is it the part where we're talking about external respiration? Okay. So we're at the part adequate ventilation does not guarantee external respiration. And then from there the hemoglobin molecules pick up fresh oxygen as it crosses the alveolar membrane and it transports it back to the left side of the heart, which at that point transports it out throughout the body, right? Left side of the heart is the biggest, so it transports that brand new, clean, shiny oxygen throughout the rest of the body. Cool? No problem. You're very welcome. All right. We will meet back up shortly. is that happening? Get back over here. All right. Everybody see me? You can't see me. All right, so we're gonna start it back. Can everybody hear me? All right, let's jump right back in. All right, so let's talk about the pathophysiology of respiration. Disruption of pulmonary ventilation, oxygenation, and respiration will cause immediate effects to the body. Some of those effects are going to be like hypoxia. So tissues and cells of the body do not get enough oxygen. That's the definition of hypoxia. Patients with chronic obstructive pulmonary disease, or COPD, as you know, have difficulty eliminating carbon dioxide through exhalation. Hypoxic drive stimulates breathing when the arterial oxygen levels fail, okay, or fall when they fall. Much less sensitive. It's much less sensitive and less powerful than the carbon dioxide sensors in the brainstem, and typically found in end-stage COPD when you start having those issues. A high concentration of oxygen should never be withheld from any patient who needs it. Onset and degree of tissue damage caused by hypoxia often depend on the quality of ventilations. Early signs of hypoxia include restlessness, irritability, apprehension, fast heart rate or tachycardia, and anxiety. Late signs of hypoxia include mental status changes, so altered mental status, a weak and thready pulse, and cyanosis. Responsive patients will report shortness of breath or dyspnea and may not be able to talk in complete sentences. Remember the 2-word, 3-word sentences we were talking about? You're gonna at that point you're gonna administer supplemental oxygen before signs and symptoms of hypoxia start to appear. Okay. Do the right thing. Oxygenate your patient. All right. So ventilation and perfusion ratio and mismatch. To exchange gas by simple diffusion, ventilation and perfusion must be matched. Okay. A failure to match ventilation and perfusion contributes to most abnormalities in oxygen and carbon dioxide exchange. When ventilation is compromised but perfusion continues, blood passes over some alveoli membranes without gas exchange taking place. The result is inadequate perfusion. The result of inadequate perfusion is less oxygen absorption in the bloodstream and less carbon dioxide removal at that point. So some factors affecting ventilation are going to be maintaining a patent airway. That's going to be one of the most critical, if not the most critical. Many intrinsic and extrinsic factors cause airway obstruction. Interruptions in central and peripheral nervous system have a drastic effect on the ability to breathe efficiently. Hypercapnia, that's the overall increase of carbon dioxide levels in the bloodstream. Trauma to the head and spinal cord can also interrupt nervous system control of ventilation as well. Muscular dystrophy causes degeneration of muscle fibers, slowing motor development and loss of muscle contractility. So you'll have issues at that point. Patients with allergic reactions might also experience a decrease in pulmonary ventilation from bronchoconstriction. Some extrinsic factors affecting pulmonary ventilation can include trauma and foreign body airway obstruction. Trauma to the airway or chest requires immediate evaluation and intervention. Blunt or penetrating trauma and burns can disrupt airflow through the trachea and into the lungs. The tongue is the most common airway obstruction in an unresponsive patient, so always make sure you check for that. And then it can result in hypoxia, the tongue can, and hinder adequate tissue perfusion. Prompt correction is going to be necessary for that, and we know what to do with that, right? Respiratory splinting can result in decreased pulmonary ventilation as well. Hypoventilation or slow breathing. So carbon dioxide production exceeds the body's ability to eliminate it, or carbon dioxide elimination is depressed to the extent that it no longer keeps up with normal metabolism. And that's when you have a hypoventilation issue. Hyperventilation or rapid breathing, carbon dioxide elimination exceeds carbon dioxide production. Hypoventilation and hyperventilation could represent the body's attempt to compensate for various abnormal conditions, such as if the body's in alkalosis, which is the high blood pH, or if it's acidotic or it's in acidosis, which means it has a low blood pH. Decreases or increases in minute volume can result in problems with carbon dioxide levels in the blood also. You can view that in a table that's in your book, 11-3. So factors affecting oxygenation and respiration, both oxygenation and perfusion need to function efficiently for proper respiration, right? External factors are in ambient air. They have a key role in the overall process of respiration. And then the attachment of carbon monoxide molecules to the hemoglobin molecules can cause false pulse oximeter readings. You remember me talking about that? We all talked about that, saying that if it bombards that hemoglobin, it's going to read 100. That's going to be or it's going to read a high pulse ox value, like they're doing well, and they're not. So watch out for that. Some internal factors, conditions that reduce the surface area of gas exchange also decrease the body's oxygen supply. Medical conditions such as pneumonia, pulmonary edema, and COPD may also result in a disturbance of cellular metabolism. Non-functional alveoli inhibit the diffusion of oxygen and carbon dioxide as well. Intrapulmonary, continuing on with factors affecting oxygenation and respiration. Intrapulmonary shunting, blood is when blood enters the lungs from the right side of the heart, bypasses the alveoli, and return to the left side of the heart in an unoxygenated state. So intrapulmonary shunting. Respirations increase or decrease based on the body's need at any given time. Pain and strong emotions can also increase respirations. Hypoxia increases respirations in an effort to bring in more oxygen. Respirations decrease as metabolism slows. Other conditions that affect the cells of the body include hypoxia, hypoglycemia, and infection. And without sufficient glucose, the cells will metabolize fatty acids, resulting in ketoacidosis. When someone goes into ketoacidosis, they have a certain type of respiration. Can anybody tell me, or does anybody remember the type of respirations that are exhibited while someone may be in ketoacidosis? Come on. Let's hear it. Kussmaul. That's right. All right. Let's see here. I want to hear an example of Kussmaul respirations. So if somebody will unmute themselves and give an example of what Kussmaul respiration sounds like. Let's hear it. Don't be embarrassed. I mean, heck, I'm the one up here making bad jokes and everything. If anybody should be embarrassed, it should be me. No, no. I want to hear it. I want to hear it over. I want to hear it over the speaker. What it sounds like. Yeah, come on. Anybody. It is that. Would you like to demonstrate? All right. Um, Tell you what. I will give 5 points on a past quiz that you've taken if you demonstrate. The first person to demonstrate. I will add 5 points. That's pretty big. That could mean the point of passing one of the quizzes. I'm ready to write down the name and what chapter quiz. I said that I will give 5 points to the person that unmutes themselves and makes Kussmaul respirations on the chapter quiz of their choice, past chapter quiz of their choice. If they unmute to the first person that does it. I don't know why I can't hear you. Did you do it?
I thought I did it. I was just like breathing in and out. I mean, kind of fast.
Did you do it?
Yeah, I got the phone in front of me.
Let's hear it. Let's hear it. I can't hear it.
Oh, man. Oh.
You gotta do it loud. It's loud. All right, try it again. I got it all the way up to 94 now. You could definitely do it now. You still there? You're still.
Yeah,
you're still
yeah.
Let's hear it. Let's hear it. Kussmaul respirations. Those are not Kussmaul. What are you doing? Are you doing? Are you doing it?
Well, never mind.
No, come on. You just gotta breathe into the phone. Just give me the breath into the phone, or whatever speaker that you're using, and 5 points, and you tell me which one. I tell you what. Since you were the only one that did it, that put in for it, then you tell me which test you want. You can send it to me by Discord, okay? Or you can send it to me in a message here in this little chat, and I'll write it down and put your name. So Torrance, and whenever you tell me, take a look and tell me what 5 points you want added to what test, and I'll do that. All right. So if you didn't hear Torrance, the sound that it makes, and I'll get close to my speaker if you can hear it. It's a. Did everybody hear that? Okay. Okay. So that's what it's going to sound like. And you'll see those patients coming in. Yep, well, that's pretty much it. Came back and sounded like a hurricane. That's yep, pretty much Kussmaul respirations. So, those Kussmaul respirations, that's what they sound like. But there's something else in ketoacidosis that you should be able to. There's a symptom and a sign that you should. You're not gonna see it, but there's something else that happens. Pursed lips, yes. Yep, they kind of have pursed lips. Yep. Oh yeah. So when someone's in ketoacidosis, there's something else that happens that lets you know on your examination, the fruity smelling breath. That's right. Thank you. I was trying to get it out there without giving a sense, because if I would have said smell, everybody would have hit it up. Yeah, mine's on the PS4, which it shouldn't even lag my system, but for some reason it does. I paid for spark, crap lights, fastest internet, so that I could teach this class efficiently or proficiently. And yep, still not happy with it. All right, moving on. I spent way too long on that, so we're gonna have to make up some time. We've hit on acid-base balance quite a bit just recently. Come on now. I'm about to have to make him get off the PS4 if it keeps lagging. Yep, it can be confused with ETOH. You can tell, Mama. So recognizing adequate breathing. Okay? So breathing should appear easy and not labored. Normal respirations, you can refer to a table, table 11-4 in your book. 12 to 20 breaths a minute. Adequate tidal volume, which means the intake of breath, tidal volume. Regular pattern of inhalation and exhalation, and clear and equal bilateral breath sounds. So that means that whenever you auscultate, then you're going to hear that clear, equal, and bilaterally. And the way that you're going to do that is you'll take, I'm going to use this cap here, and you'll put it, you'll do apex, and then lobe, 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 right? Or, I'm sorry, wrong side, right? Lobe, lobe, lobe. I was looking at the camera. And when you do the lobe, 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 then each time that you repress, you'll say deep breath in and out. Deep breath, or you can say deep breath in, out. But usually what I do is take a deep breath in and out. And then I'll go down and I'll say take a deep breath in and out. And then I'll come up here. Oh, I'm sorry. I did that absolutely wrong. Good Lord. So in and out, in and out, in and out, in and out, in and out. Okay? And that's what I'll tell a patient whenever I'm doing that. And on the back, the same thing. Take a deep breath in, out. Take a deep breath out, in, out. And you gotta direct them. All right, so recognizing inadequate breathing. An adult patient who's breathing at a rate of fewer than 12 breaths a minute or more than 20 breaths a minute should be evaluated for other signs of inadequate breathing, right? Patients in respiratory distress often compensate with preferential positioning, like we're talking about the tripod positioning, or whichever way. And a lot of times, you don't want to lay those patients down on their back if you can help it. You let them sit up, you let them be comfortable. Because distress it exacerbates issues, right? So respiratory distress may be the result of upper or lower airway obstructions, inadequate ventilation, impairment of the respiratory muscles, impairment of the nervous system. Any difficulty in respiratory rate, regularity, or effort is defined as dyspnea. Dyspnea may be the result of hypoxemia. What do you think hypoxemia is? Just think hypox. We already know that hypooxygen. So, and then emia. So low blood oxygen, right? Or low oxygen in the blood. Untreated hypoxia result in anoxia, and death of the body cells and tissues. So a lot of times in a patient that has an anoxic, so an meaning lack, oxic meaning oxygen, so lack of oxygen. So anybody that's in an anoxic state, and that death starts to occur, that death of the body cells start to occur, a lot of times you'll see that because they'll be altered. Another thing that'll happen is something called trismus. Does anybody remember what trismus is? Give me a quick one. What is trismus? If you can see the camera. It's when the teeth, they lock up, the mouth locks up. Not biting, but so it's when their teeth and it clamps, clenching. When you're clenching, RSI. So they'll clench, and at that point, yes, you would have to RSI a patient in order. That's how you fix it. Rapid sequence intubation. But we can't do that as AEMTs. In the state of Mississippi, we can't do that as paramedics unless you're on the helicopter. You were critical thinking. Way to go. Recognition and treatment of dyspnea are crucial to patient survival. So we got to do it. Treatment of the patient will be ineffective if the airway is not patent and the patient is not breathing adequately, all right? Evaluation of the patient in respiratory distress includes observations, palpation, and auscultation. So observations, what you see, observing. Palpation, put your hands on them. And auscultation, listen. Okay? When you assess a patient with respiratory distress, how is the patient positioned? Some of the questions you're going to ask. How's the patient positioned? Is he or she in a tripod position with their elbows out? Is the patient experiencing orthopnea? Okay. Is there adequate rise and fall of the chest? Is the patient gasping? What is the color of the skin? Is it blue? Is the skin moist or clammy? Is there flaring of the nares of the nostrils? These are things we have to ask. No. I haven't seen one of those. Well, I take that back. I have seen one of those in an old ass bag. What's some other way that we may do it? BVM, right? All right. Is the patient breathing through pursed lips? Do you note any retractions? If you remember us talking about retractions, is the patient using accessory muscles like their belly to breathe? Is the patient's chest wall moving symmetrically, or is it paradoxical movements? You remember that? Paradoxical movements? Okay. And then is the patient taking a series of quick breaths followed by a prolonged exhalation phase? So kind of deal. So patient with inadequate breathing may appear to be working hard to breathe or have labored breathing. Good word for documentation, labored breathing. Accessory muscles are not used during normal breathing. So that sternobasculoid, I'm trying to make the face so you can see them when they're trying to breathe. Okay, that was pretty good. That was actually pretty good. So you see that sternobasculoid. So at that point, that's accessory, kind of like accessory muscle use. Pectoris major, I'm not showing those. Rectus abdominalis, so I'm not gonna do that either. But their belly will poke out. Mine does that anyway, so it always looks like I'm in constant respiratory distress. Some signs of inadequate breathing in adults are respiratory rate fewer than 12 or more than 20 breaths in a minute, and that's dyspnea. Irregular rhythm, such as a patient taking a series of deep breaths followed by periods of apnea, like Cheyne-Stokes. If you remember Cheyne-Stokes, what is that? Cheynestokes. Cheyne-Stokes. It almost looks like Cheyenne Stokes or Shaney Stokes. Maybe. Diminished, absent, or noisy auscultated breath sounds. Abdominal breathing. Reduced flow of expired air at the nose and the mouth. Unequal or inadequate chest expansion throughout the reduced tidal volume as well. So you'd also have the increased effort of breathing, shallow breath, or shallow depth, skin that's pale, cyanotic, or blue, cool, mottled, or moist, retractions, we've talked about that, staccato speech patterns. Staccato speech patterns is the one or two word sentences. So pay particular attention to the external environment. Auscultate breathing with and without a stethoscope. Okay, so listen to it with your ears and then listen to the lungs after that. Feel for air movement at the mouth and nose. Doesn't mean you have to put your ear right up in. Now, if they're laid down, knocked out, you may be able to do that. But other than that, you should be able to feel it. So note the paradoxal movement, or evaluate for pulsus paradoxus. So it's when you take a pulse. So you take a pulse in the wrist, and they're different. You got one bounding pulse, one weak pulse. That can mean something as well. A history of present illness is a vital part of your assessment. Okay. So you're going to note protective reflexes of the airway. So sneezing clears the nasopharynx, is often caused by an irritant such as dust. Sighing and hiccuping are other modified forms of respiration. And then there's a table 11.5. Welcome back, Hannah Banana. It's said you were out for a minute. Serious head injuries can also cause changes in normal respiratory rate and pattern of breathing. The results may be irregular, ineffective respirations, or may not have an identifiable pattern, like ataxic respirations. So if you look there, you'll see Cheyne-Stokes breathing, and that's what I was talking about there. A patient may appear to take a breath after his or her heart has stopped, which we call agonal respirations or agonal gasps. So you got to be vigilant when monitoring patients in respiratory distress. And patients with inadequate breathing have inadequate minute volume and need to be treated immediately. Emergency medical care includes airway management, supplemental oxygen, and ventilatory support for your patient. So a patient's level of consciousness, assessment of respiration, assessment of respiration, a patient's level of consciousness and skin color are excellent indicators of respiration. Uh, when treating patients with an altered mental status, always consider the possibility that the patients may not be getting adequate oxygen to the brain. And determine a baseline and mental status on the patient. So when you first show up, determine that baseline mental status, and then we start trending from there, right? Trending. 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 As oxygen fails to reach the skin from a lack of perfusion, the color of the skin changes to reflect the inadequate oxygen. If you ever taken your finger and wrapped it up with a string or something like that, then it'll start to turn colors because of lack of oxygenated blood getting into it, and so that's variably what happens. Pale skin and mucous membranes are associated with poor perfusion caused by illness or shock. So you need to consider oxygenation when assessing all of your patients. Always consider it. There are several methods to be used to assess proper oxygenation. Pulse oximetry is one. It's simple, rapid, safe, and non-invasive method of measuring how well a person's hemoglobin is saturated. Routine vital signs can be used as part of any patient assessment. A pulse ox measures the percentage of hemoglobin in the arterial blood that is saturated with oxygen. So if the hemoglobin's got all four oxygen molecules on it, it's going to say 100, or it's going to say 98 or 97 or above 94, above 95. If it's not, then it's going to show something else entirely, or it's going to be lower. So to ensure that the instrument is measuring arterial blood and not venous oxygen saturation, pulse oximeters are designed to assess only pulsating blood vessels. Okay. Functionality can be checked by comparing the pulse reading with the measurement obtained by palpation. Okay. Situations in which a pulse ox may be useful in pre-hospital include monitoring oxygenation status of a patient during an attempt to insert advanced airway or during suctioning. So you put it on there, and if you're suctioning the patient for quite a while and you start to see that pulse ox start to lower, then you need to be like, whoop, let's back off. We're below 94%, or we're below 95%. Let's back off. Let's give some oxygen. Let's oxygenate and then hit again. Or let's say you're trying to get an airway on that patient, and you got that thing set up there, ripping and roaring, and you're trying to put an advanced airway in there, and you start to see that blood oxygenation go down, or you start to see that pulse ox start to go down. Whoop, we're at 95%, or it's dropping this much, 94%, 90%. Let's do over. Let's start this up again. Another thing is you're going to use it if you have it on a monitor, a patient on a monitor. You'll see that as well on there. One thing that I'm a big fan of, if I'm working with a patient and I'm trying to intubate a patient or do an advanced airway of any type, or trying to get an airway of any type, or if I'm suctioning a patient, I'll do something called passive oxygenation. Passive oxygenation. It's not something that's used readily in the field. It should be because it's fantastic. It works. So what I generally do is I'll take that patient while I'm preparing. So when I first get in there, when I first get into the building or into the house or into the yard or into the car or whatever, I will take a nasal cannula and I will put it on. I will put it on the O2 cylinder, and I will crank it up to 100. 100. I'll crank it up to 15. That's what I mean. So I'll crank that thing up to 15, and it is going to be blowing and going. This is for an unconscious patient, a patient that's unconscious, okay? But what I do is I'll take and put it on that unconscious patient, put that nasal cannula on, and it's forcing, called passive oxygenation. it's forcing oxygen into their nose, into their system, and that's going to help you keep that SpO2 level that much higher while you're preparing. Because as you're preparing, that patient's SpO2 level's dropping. But you can hold that off, or you can slow that if you give that partial oxygenation. And you could variably save that patient. You also make it a lot easier to save that patient or to get that patient oxygenated if you're not lacking that. Okay, so at that point, once I get it on, I get the BVM on. I'll start hitting it up, change it out, put the 100 on there, and rip and roar. Got it? Does that make sense to everybody? That's good stuff. You won't get that anywhere else. All right, some of this other stuff is arterial blood gas analysis. We don't do ABGs here. You do them at the hospitals. If you want to know more about them, take a look at them in your book. They are very good at getting those air blood gases, at giving you a more in-depth assessment. But we don't do ABGs. We don't have ABG machines in our trucks, so we can't do them most of the time. And they're not in any of our trucks anyway. In-tidal carbon dioxide assessment. I told you, I'm a huge fan of this. In-tidal carbon dioxide assessment the monitor detects the presence of carbon dioxide and exhaled air, right? So types of monitors include a colorimetric digital. We looked at those, and some pictures are going to pop up here in just a minute. There we go. So a colorimetric carbon dioxide detector, which is the top one, it provides qualitative information regarding presence of carbon dioxide in a patient's exhaled breath. Okay. It might give a false positive reading if the patient has carbon dioxide trapped in the stomach from ingested of carbonated beverages. It could give a false reading. It's sensitive to extremes of temperature and humidity. So your roll kits, where those are located, they need to be inside the truck, not thrown on the dash, not out in the damn sun and everything else. Take care of your stuff. Take care of your shit. Because once you open that bag, it can actually change if you keep it out too long. So it can actually change color. So best thing to do is when you're ready to put it onto the BVM, you need to tear the bag open, put it on, put it on, make a couple pumps. Yep, change. It changes color. Once it changes color, you're good to go. Okay? And then once it changes color once, it's done. Throw it away. And then you also have a capnometer that provides a quantitative information in real time by displaying a numeric reading of the exhaled carbon dioxide levels, which is at the bottom, EtCO2. Which now you have EtCO2 measurements on your machines. If you have one in your truck or if you're riding with a paramedic, use them. Please use them. And you'll notice them. They have a little orange cap on the end where it plugs up into the machine, as well as when you put it on, it's got the two that looks like a nasal cannula with a balloon or something, a little circular thing at the end of it. And what that does, it goes in the mouth, or it goes on to the top of the mouth, so it catches that area as well. And then you read it from there, and you'll see, and as you see here on the slide, you see what's called a waveform. So a capnographer or a capnometer provides. A capnometer it's a device that provides that graphic representation of exhaled carbon dioxide levels. Waveform capnography provides quantitative real-time information regarding the patient's exhaled carbon dioxide level. It's very good stuff. It's the gold standard. There it is. There, look at that. The quantitative waveform capnography is the recommended method of monitoring initial and ongoing placement of an advanced airway. You can put that onto there. You can see the bottom one. It goes in between the ET tube and the BVM, and then it'll read that waveform, and it's the best thing to have. You should put it on every patient that you got a BVM. You should put it on sick patients. If you have a sick patient, put that on there. Okay. Capnography it can also serve as an indicator of the effectiveness of chest compressions. So it can help you perfect your chest compressions, and it detects the return also of spontaneous circulation. So return of spontaneous circulation, or ROSC. All right, you will see those words, or you will see that acronym again, ROSC. You're going to use ETCO2 monitoring, use ETCO2 is limited with patients in cardiac arrest. Okay, and it's going to be limited because you're not going to catch a waveform. But if you use it during and you're going to be able to see those levels. If all of a sudden you see that ETCO2 level kick up, then you're like, oh, wait a minute, it gets to about 35. Then you're like, we got ROSC. We're on it. We're good. We just saved this man's life. Where's my pen? Where's my pen? Got it? Opening the airway. So we know how to open the airway. If you don't know how to open the airway, please check your skills drills. YouTube it if you've never done it before. Okay? I'm not going to get too far into this because we've talked about doing this. All right, so suctioning. The airway must be kept clear to ventilate the patient properly, all right? If the airway is not clear, material can be forced into the lungs. This can cause a complete airway obstruction. Suctioning is your first priority when that happens. And if you hear gurgling, the patient needs to be suctioned. If you hear the gurgling, suction them. Okay? Suctioning equipment, portable hand operated, suck. And fixed mounted types. Portable suction unit provides enough vacuum pressure to flow to suction of the mouth and oral pharynx. You're out? You talking about with the hand suction? Oh. Well. What are you talking about? That's not even that bad. So those respiratory folks, wait till I'm good. Oh, when you do your hospital rotation, I'm gonna figure out where you're at, because I'm gonna ask them to get you to do the a tracheal suction. That's what that sounds like. Or when you have to get a sample, when you have to get a phlegm sample, or you have to suction out that ET tube. Oh my gosh, that's yummy, yummy. I'm gonna call them. It's fun stuff. So a portable and fixed suction unit, it should be fitted with a wide bore, thick-walled, non-keeking tubing. You should have that on there. A soft and rigid suction catheters, or what we call a yonker, or what do we call the soft one? Y'all remember? We call a soft suction, right? and we do, and it's measured in Frenches, right? Frenches. Learn those. You should be able to get into your medic bag and know exactly where everything's at. Put your hand on everything. Okay? And then you also got to have a supply of water for rinsing the tips. What do I know about them? I've used them. Hell, I've used one recently. Because somebody at AMR did not charge the battery on their suction. Or it wasn't charged, or the battery was dead, or whatever. Whatever it was, they weren't taking care of their suction. Ended up having to use a friggin' hand pump suction sitting right there. They were like, "You got one of those?" I was like, "Hell yeah, I got one of these. Back up so I can show you what to do." No, this ain't Stonnet. This ain't Stennis. This was out in the county. Only went full time at Stennis February. Or actually, it was March. In March, I went full time at Stennis. No, we don't respond outside of Stennis. I mean, we can, but it's for aircraft accidents. I'd be a paramedic for free if somebody else would do the documentation. I would do it for free every now and then. Not all the time, but every now and then. At the base in Camp Shelby? At the base at Camp Shelby, we did. At CRTC, we did all the time. At CRTC, we ran with the county all the time. They still do. They still run with the county all the time. That's part of our mutual aid training program. There is not a better mutual aid training program in the entire state of Mississippi. You can't convince me that there is. Love our mutual aid. All right, there's some more stuff. Never insert the catheter past the base of the tongue. Right? Always measure for proper size. So the soft plastic ones can be used for the back of the mouth and patients with a stoma. Suction times, 15 seconds at one time for an adult, 10 seconds for children, 5 seconds for infants. We always check our suction. How do you check your suction? How do you properly check your suction? How do you test it to ensure there's vacuum pressure of more than 300 millimeters of mercury? I need somebody to tell me this. You don't just turn it on and let her fly. You have to turn it on and do what? That way we all know. No. Dear God. Finger over the hole and touch to your gloved finger, right? Clog it up. Take it off. You can take the yanker, just take the yanker off, use the tube, and put it over the tube. You put your thumb over the tube, and then once you put your thumb over the tube, it'll kick up, and then you'll see it pinging past 300. You're like, good to go. But also make sure it's charged. Do not embarrass yourself. All right, pass suction catheter and ET tube, good stuff. Airway adjuncts, we're not going to get too far into those. You guys are EMTs. You should definitely know oropharyngeals. You should definitely know nasopharyngeals. You know what Lefort fractures are? Who can tell me what a Lefort fracture is? You guys know what supplemental oxygen is, liquid oxygen. So the pin indexing system that keeps it from being connected to a carbon dioxide cylinder. Yep, that's right. Lefort fractures, facial fractures, right? The triangle of the face. All right, those are the areas where my fingers are at. Those are the areas that can be fractured and be a Lefort fracture. If you have anything like that, then you don't need to. What is the separation from? I mean, you get hit in the face or anything if that's what you're talking about. But if you have a Lefort fracture or anything, no MPA. No MPA. That's right. Good to go. So if you have a Lefort fracture or possibility that there's a Lefort fracture, no MPA. Do not use the nasopharyngeal airway. This is some stuff that we are going to go over. So if there's excessive oxygen levels in the blood, then you can give what's called oxygen toxicity. That's why it's important that we trend our patients and we watch our patients as we start to do our treatment. Okay, that pulse ox needs to stay on them. The SpO2, and see, it's important to make sure we stay on top of that, as well as keep checking your EtCO2 and what have you. All right, let's take a 10-minute break. And then we will get back at it. All right, can everybody hear me? All right. I wonder if that mute works. It does work. Awesome. Sorry, my little boy came in and wants me to look at something on Minecraft. Of course. All right, let's rock and roll. So oxygen delivery devices. Oxygen delivery equipment that is used in the field should be limited to non-rebreathing mask or NRBs, bag mask devices, and nasal cannulas. Somewhat. I got the hiccups. The non-rebreathing mask or NRB is preferred device in the pre-hospital setting. Contraindications include apnea. It doesn't work very well in apnea, and poor respiratory effort doesn't work very well there. In both of those cases, if you have apnea or poor respiratory effort, what device should you be using? Should be using a BVM, right? Should be using a BVM. There's a non-breather there. Everybody knows how that works. You know how to fill it up. So if you don't know how to fill up a non-breather, then what you're going to do is where the bag's at, right here. Let's see if I can. Oh, I can. Look at that. So you can see where the bag's at right here. Yep. Right here's the bag. So right here, I don't know why that thing's trailing so bad. Something just happened. All right, hold on. Having some technical difficulties. Let me fix it. doing so well. Now all of a sudden it's not wanting to do as well. All right, hold on. Let me fix it. I have to change out. I should have known better. All right. Let me pull this back up. All right, can everybody see me, and can you see the slideshow? Did the slideshow pop back up? Awesome. Great. All right, let's rock and roll. That was weird. All right. Now I gotta fix all my stuff again. All right, rocking and rolling. All right, so we went over that. There's different sizes of it. You can use it. You can use a pediatric mask for infants and children as well. Nasal cannula. As you know, it delivers oxygen to the two small holes. We know what that does. If you're doing a long transport on a nasal cannula, you may want to consider humidification. So humidification, it looks like a little water bottle, a square or a cube water bottle. You hook into it, and it helps humidify that oxygen in there. It keeps them from drying them out, or it keeps them drying them out too bad after being on it for so long. It's usually the preferred method for those that can take it, and it's more tolerable as well. So partial rebreathing mask, that's just a normal breather with no bag, right? So it's good for patients that are experiencing hyperventilation syndrome. And then you have Venturi mask. It's got a bunch of attachments. You can see there the color, and the air is drawn into the flow of oxygen as it passes through the hole in the line. You can the different colors vary. You can vary the oxygen as it goes through there, 24 to 40%. Tracheostomy mask, just like it says, goes right over the tracheostomy. Or you can place a mask over the stoma as well. There's an oxygen humidifier right there. Got to have sterile water. Assisted assisted ventilation. So a patient who's not breathing needs artificial ventilation at 100% supplemental oxygen. Assisted and artificial ventilations are probably the most important skills in EMS. The basic airway and ventilation techniques are extremely effective when administered appropriately, and an irregular breathing pattern will also require um, artificial ventilation. Fast, shallow breathing moves air primarily in the larger airway passages and does not allow the adequate oxygen of or exchange of air and carbon dioxide in the alveoli. Signs of AMS or altered mental status and inadequate minute volume are indications for assisted ventilations. Excessive accessory muscle use and fatigue from labored breathing are signs of potential respiratory failure. And two treatment options for that is assisted ventilation or continuous positive airway pressure or CPAP. Okay, which is an awesome tool to use. If you hear a lot, if you listen to the lungs and you're hearing a lot of crackles, sounds like they have pneumonia pretty bad or what have you, that CPAP works out fantastic. It helps push that fluid out of the lungs. It's not tolerated very well, but you have to explain to the patient that even though it's uncomfortable, it is breathing for them. It's doing well to breathe for them. It's assisting them. It's helping them. Whatever you got to say to make that better. So, artificial ventilation. You're going to begin artificial ventilation immediately once you determine patient's not breathing. Artificial, fake breathing, right? So, normal ventilation versus positive pressure ventilation. Artificial ventilations are not the same as normal breathing. During normal ventilation, the diaphragm contracts and negative pressure in the chest cavity sucks air into the chest. Positive pressure ventilation, generated by a device, forces air into the chest cavity from an external environment. Okay? Positive pressure ventilation causes the wall of the chest cavity to push out of their normal anatomic shape. There's an increase in overall intrathoracic pressure within the chest cavity at that point. Venous blood flow is decreased due to the increased pressure in the chest. AMTs, as an AMT, you must regulate the rate and volume of artificial ventilations to avoid distension of the chest wall. You don't want to distend it out too much. The force generated from positive pressure ventilation allows the air to enter not only the trachea but also the esophagus. So you got to pay attention. There's a big time potential risk of gastric distension. And once you get enough gastric distension, what happens? You have an emesis attack. That's right, vomit comet. Um, Mouth to mouth and mouth to mask ventilation. Mouth to mouth ventilation is routinely performed with a barrier device, some sort of barrier device. Mouth to mouth, excuse me. Mouth to mouth is the most basic form of ventilation. It includes a risk of unknown communicable diseases and psychological barriers there. Mouth to mask. Mouth to mask ventilation, if you have to do something like that, is preferred. It places a physical barrier between your mouth and the patient's mouth. Most masks offer a one-way valve to prevent exposure to blood, bodily fluids. That's not good. It's also easier to secure on an effective seal with a mask on there. A mask with an oxygen inlet provides oxygen during mouth to mask. Right. But I'm going to use my good sense, and I am going to use my BVM and use my good sense not to overinflate and blow out a lung. I, that's what I'm going to do. Uh, all right. So there is your BVM, your bag mask device. It can deliver nearly 100% oxygen. Nearly. It can deliver only as much volume as you can squeeze out of the bag by hand, but does not mean that you need to squeeze the entire bag out by hand to get what you need. Okay. It's the most common thing that's used in the field. It's a difficult skill to master. Why, you ask? Not for pumping the bag so much as keeping the seal. The seal is the hardest thing. That EC, there's a reason why they teach that EC clamp, and that's because it works. If you have enough people there to do so, get somebody to clamp that bad boy on there with two hands, and then you pump. Other methods that you can do is you can take and get in between, put their head between your legs, like you're supporting their head and neck, and you put their head between their legs. Their ear should be between your knees as you kneel down, and then what you do from there is you can do that EC clamp. You're more on top or over the patient, and then you can actually use your leg to help you deflate the bag as well. But just remember, the patient, the tidal volume on an adult patient, it's not the 800 to 1,000 milliliters that an adult bag actually has. It's nowhere close to that. It's between 450 and 500 milliliters. Um, that's why I've said it before. That's why I always carried a pediatric bag uh, in my kit, because the pediatric bag or the child bag actually was, I think it's 450 to 500, and that's exactly what I need, right? To do it in there. Do it to it. The bag that this person's holding right there is a pediatric bag. So delivered chest rise and fall, visible chest rise, a delivered tidal volume of 5 to 600 milliliters per breath will produce visible chest rise and fall. There you go. If you do it too fast or too hard, you could either blow lung out, or you could cause gastric distension, and you also can cause a decreased blood return to the heart. So that's why you got to make sure that you're doing good. Uh, Also, some of these will have a PEEP device or some sort of pop off valve, and if one's present, it it makes it to where you're not gonna go over that pressure, that amount of pressure. Also, there's a way to hook up your ETCO2 there as well, which you should always. Capnography, gold standard. Do it to it. If you have the availability to do so, do it to it. The bag mask device technique. It's a challenging skill. I just told you. You got the main thing is you're going to have to make sure that you put that you get a good seal. If you try to do a quick and forceful delivery, like you try to with that bag instead of doing an even squeeze, you're gonna it may result. You're more likely to result in gastric distension because the small amount of pressure to override the lower esophagus sphincter is what you're gonna cause if you're doing that. There's the two person. There's a picture of the two person. If you have that many people, you're good to go. If you're alone, there's the EC. If the patient's intubated, you don't have to stop. You don't have to stop the ventilations. Just keep on trucking. Manually trigger ventilation device. Make it easier. You don't see many of them anymore. So the manually triggered ventilation, if it's got a demand valve, it's triggered by the negative pressure generated by inhalation. It delivers almost again 100% oxygen. It's going to allow a single respirator to use both hands to maintain a mask to face seal because you're not having to squeeze a bag with it, and it's going to reduce that fatigue from having to do all that work as well. It is associated. It is associated with difficulty in maintaining adequate ventilation without assistance. It should not be used um, routinely, and special unit additional training are required for it as well. It's it makes it almost virtually impossible to assess for lung compliance with that. When we talk about lung compliance, that's the filling, the total filling of the lungs. There's a good video when we start talking about chest injuries and things like that. I'll show you exactly what lung compliance is because we're going to talk about chest needle decompression very shortly, just enough to show you a video of what it does. And there's an awesome video of great recruitment of the lungs and that lung compliance from the chest needle decompression kit. No, 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 no. Not chest needle decompression. No, 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 you cannot. If it causes too much pressure, you can end up with a pneumothorax resulting from it. There you go. So automatic ventilators or resuscitators, it allows variable respiration. Oh, I'm sorry, variable ventilation, and it can be precisely set in there. You can set the ventilator rate, tidal volume, and peak inspiratory time, as well as size and everything else can be in there. We're not going to get too far into the use of the ATVs because you don't see very many of them anymore, or you don't see very many of them on our units or anything like that. You always need, any time that you are doing work with a patient and you're doing breaths, whenever you get everything set up, after you're finished setting up and you're giving those breaths, you need to let somebody or you, uh, or, well, they're on the helicopter, so you've probably seen one hanging in there. Um, but you need to auscultate breath sounds to make sure that you're getting it right. Okay, everything's set up correctly. You're getting it right. Get somebody to auscultate breath sounds, or you auscultate breath sounds. Make sure you can hear it coming in. Clear, equal, bilateral. So there's the CPAP again. Some people use it at night. Uh, it's used by people at night with obstructive sleep apnea. And then early intervention with CPAP is an alternative means of providing ventilatory assistance. It can prevent the need of an ET intubation, because ET tube in the throat is not good for you. It's not good for your cords, or anything like that. It's pretty rough getting it in there. It's pretty rough. It's not the gentlest. So CPAP's going to increase pressure in the lungs. It opens collapsed alveoli and pushes more oxygen across the alveolar membrane. Like we talked about before, those that have fluid in their lungs, pneumonia, things like that, it's going to help push that. It's going to help decrease that dead spacing event as well. Got to have a good seal in order for it to work correctly. Some indications of CPAP, and I think this is important to know. Indicated patients experiencing respiratory distress in which their own compensatory mechanisms cannot keep up with their oxygen demand. That is what you may need to use CPAP for. So, general guidelines for CPAP candidates: the patient's got to be alert and able to follow commands. Uh, Obvious signs of moderate to severe respiratory distress. Respiratory stress after a submersion incident. Well, why do you say that? Remember what I said? It pushes that fluid out. Rapid breathing, so more than 26 breaths a minute. And then pulse ox that's less than 90. Those are good candidates for CPAP. Some contraindications to CPAP are going to be the patient is unresponsive or otherwise unable to follow verbal commands. Unresponsive, right? Respiratory arrest or agonal respirations. The patient's unable to speak. The patient is unable to protect his or her own airway. Hypoventilation, or breathing too slow, because they're not, it requires you to do work with it. Hypotension, so blood pressure is too low. You don't want to use it then. Signs and symptoms of pneumothorax or a chest trauma. You don't want to use it then. And then closed head injury. You don't want to use it at that point. Facial trauma or cardiogenic shock. You don't want to use it at those points either. Tracheostomy. Not really going to do you any good, right? Active gastrointestinal bleeding, nausea or vomiting. It's not going to be a good thing to use it on. History of gastrointestinal surgery or surgical procedure. You don't want to use it on there. Patients unable to set up. Inability to properly fit the CPAP system, mask and the strap. Excessive facial hair or dysmorphic facial features, such as some of your cancer patients or people that had cancer patients had surgery for jaw removal or anything like that, partial jaw removal, some sorts of injuries or scar tissue, things like that could be an issue. And then the patient, if they just can't tolerate the mask. But with the tolerating the mask, you need to have that conversation with them. And once you get it on there, they're going to try not to tolerate it. You got to talk them into it. Sometimes you got to be a little firm, because you're going to tell them, this is helping you. No matter what you think is happening, this mask is helping you. And sometimes they eat it and go. Sometimes they tell you to eat it and go. So applications of the CPAP, there are several varieties of CPAP units that are available. You got CPAP units are generally composed of a generator, a mask, a circuit that contains the corrugated tubing, a bacteria filter, and a one-way valve. The patient exhales against the resistance, uh, called the positive end expiratory pressure, or the PEEP. The PEEP maintains pressure in the lungs at the end of exhalation and keeps the open alveoli from collapsing. So it's going to keep that. It's like pushing air, pushing air, pushing air, or pushing that oxygen, pushing that oxygen. Some some CPAP models have PEEP valves that connect separately. The PEEP is controlled manually, adjusting the PEEP using a what's called a manometer or a manometer, or predetermined by a fixed setting on the PEEP valve itself. Just know which ones that you have and practice with them. Most CPAP units are powered by oxygen, and then and a lot of it. So you got to make sure you have a good amount of oxygen, have a full cylinder, and then proper planning of oxygen consumption is definitely necessary because of that. And you need to know how much it uses, because that that gauge on your oxygen bottle isn't just so you can see it hit 2,000 for full, 1,000 for half, 500. We need to change it out. Uh, that's You can actually measure how much oxygen that you're going to use on that device by using that. Rob, you should remember oxygen calculations, O2 calculations, except doing it on a truck is just slightly different. There are some complications of CPAP. Uh, some of those compli- some of those complications can be they find it claustrophobic. Oh, he left the building. Okay. Well, so a possible to cause a pneumothorax as a result of barotrauma. Barotrauma means too much pressure, right? Increased pressure in the chest cavity can also create hypotension. Why do you think that is? Why do you think it would create hypotension? Because it's going to create hypotension. Think of it. Think of pathophysiology. If the lungs are constantly inflated, where's the heart? Where's the heart located? What is the area that the heart is located? Yes, in the mediastinum, and it's constantly pushing on those arteries and vessels or crap. I don't know why I'm the arteries and veins, things like that, the main, everything else, and then it creating that pressure, it's not going to be able to pump as adequately, and then it causes it to lower. Mm, it may cause that. I mean, usually JVD is because of a backup issue. Special considerations with it is inflation of the patient's gastric distension is pressure. Yeah, yeah, I know where you're coming from. Inflation of the patient's stomach with air, gastric distension. It's likely to occur if excessive use of inflated lungs. How do we mitigate that? How do we mitigate gastric distension other than letting them puke? What are some things that a paramedic can do that can help mitigate that? And if they don't have them on the truck, they can do it in the hospital. Anybody want to take a shot at that? At that. So you can place an NG tube. You place an NG tube in. and it goes in, into their gut, then it'll release pressure, release some of that air. NG tube will. Boom, shakalaka. There's some more special considerations. Suctioning of the stoma. So, a failure to recognize and identify the need for suctioning could result in hypoxia, which is not good for patients. Yes, that is in the scope of a medic. But that's why I was asking, because sometimes you need to tell your medic. You're going to limit that suction by 10 seconds. What? You never heard of using an NG tube? Well, it's a nasogastric tube. Mouth to stoma technique. That's good stuff. So, tracheostomy. Yeah, can relieve gastric pressure with it. Require 15. So, tracheostomy tubes require 15 to 22 millimeter adapter to be compatible with ventilatory devices. So make sure you got at least one or two with you. Ventilation is accomplished by simply attaching the bag valve mask to the 15 millimeter adapter on the tracheostomy tube. And then when tracheostomy tube becomes dislodged, stenosis or narrowing of the stoma may occur. So, yep. The patient may be less tolerant of even brief periods of hypoxia. Nope, you can't use that word, Rob. Humans cannot multitask. If the term multitasking only means that it gives you an opportunity to fail at a lot of things. Multitasking, that's all that means. Gives you an opportunity to fail at a lot of things. There's a book. There's a book that you should definitely read called The One Thing by Gary Keller. Fantastic book. I've read it twice so far. Do it. It's an awesome book. All right, dental appliances. Many dental appliances can cause an airway obstruction. Loose dental appliances should be manually removed before providing ventilation. Here's a story. It's not a war story. It's a learn from me story. So I'm in paramedic school. I'm at Garden Park. I'll even say it. I'm at Garden Park Hospital, and we get a patient in, and this doctor, I really like this doctor. He's an awesome doctor. A Band-Aid station. What are you talking about? Band-Aid station. We've done a lot of good things there. You got to get out more. You're from Stone County. How do you call that a Band-Aid station? So anyway, we're sitting there. We're sitting there, and this doctor comes up to me, and he says, "Hey," he says, "you have intubation yet? Do you have your intubation check off yet?" And I said, "No, I haven't had the opportunity to do so yet." So it's my first intubation, very first one. So it was Dr. Marsh, awesome guy. He's awesome guy. So Dr. Marsh calls me in there, and he says, "Okay, He says, your first intubation. He was like, this person needs to be intubated immediately. Here's your tools. Here's your tube. Here's your suction. Good luck. And so I get down there, and I insert using a Mac blade. And so I insert. I do my lift towards the ceiling, just like you're taught, or I sweep the tongue, lift towards the ceiling, just like you're taught. And then I go to put the tube in, and right as I go to put the tube in, the dentures go bloop and fall in. And of course now I'm I'm a medic student. I'm pretty confident at this point until the dentures fell in. Once the dentures fell in, jacked me all up. And Dr. Marsh looks at me and says, yeah, I knew she had dentures. I guess I could have told you, but this is a good learning experience for you. So I reached in, I let go, reached in, pulled and now I'm all jacked up. Now I'm shaking and everything else. And I try again, and I couldn't get the damn tube. And I ended up finally getting it. But he did commend me. He did commend me because I used the passive oxygenation technique that we talked about earlier, and he said that was unique to see somebody doing passive oxygenation like that. It was relatively new to do that at that time, but I wanted to try it out, and it worked. Passive oxygenation, like we talked about, awesome stuff. That's going to save lives. All right, so facial bleeding. Airway problems can be especially challenging if patients with serious facial injuries. You're going to control the bleeding with direct pressure and suction as necessary. When inserting a type of airway device, any type of airway device, it's imperative to maintain inline stabilization of the cervical spine. Okay? Keep doing the basics. The basics, the fundamentals. So here's a few airway devices. King Airway, awesome stuff there. It's latex-free, single-use, single-lumen airway that's blindly inserted into the esophagus. It can be used to provide positive pressure ventilation to apneic patients. It helps maintain a patent airway in unresponsive patients who are breathing spontaneously. And then it also, the device consists of a curved tube. Yeah, well, it's fast. It's fast. Why sit there and dwell? I'm so in a lot of in some EMS agencies, it's like a rite of passage to be able to insert an ET tube. And in a lot of ways, if you're a good medic, you should know how to insert a good ET tube. And you should be proficient at inserting ET tubes. But here's what I'm going to tell you. If you can't insert that damn ET tube, then do something that you can insert. Do not hang out and sit there and try to constantly, pound that ET tube, pound that ET tube. If you can't get it, you can't get it. Go with the King Airway. Go with some other airway. Go back to the damn basics if you have to. And do, BLS that patient in there. The thing is don't get stuck on that ALS procedure. Don't get stuck on an ALS procedure when your fundamentals, your basics can save somebody's life just as well. Okay? I think all too often we don't, paramedics, as paramedics, we got to get this tube. We spend too much time on it. You're not saving a life at that point. You're trying to measure. You're trying to make measures. And that's not how we do. That's not being a patient advocate. Yeah. So you're creating throat trauma. Yes, you are. But also you're messing around with that epiglottis like we talked about. And what did I say? If you messed around with that epiglottis, oh my goodness, that epiglottis. Well, not trismus, but if you mess around too much with it, you'll end up vagling that patient, right? Okay, you'll trigger that vagal sense. You can, if you mess around with it too much or anything, and it starts to get, you know, certain things start happening. You could end up with a laryngospasm. And if they end up with a anoxic brain injury, then yes, trismus could happen at that point. So do what you can do. Did I miss one? Nope, we got that. So can be used to as a rescue airway device. We talked about that, the King LT. There are two types of King LT airways that are available: the King LTD and the King LTSD. The King LTSD is a more commonly used device, and it's available in 7 sizes. The distal end of the King LTD is closed, whereas the distal end of the King LTSD is open. So some indications of and contraindications for the King LT. Alternative to bag valve mask ventilation when a rescue device is required for a failed intubation attempt would be an indication. And then contraindications are going to include it does not protect the airway from the effects of vomiting and aspiration, and should not be used in patients with an intact gag reflex. Go figure. Versus Combi Tube, better or worse? Yeah, I like the Kings a little bit better. But here's something that I'm a fan of that we don't see very often. You see it on the military side, and I got a feeling that it's going to make its, if it wasn't so damn expensive, it would make its way into more ambulances, or actually, I think that fire departments should be using it, or EMTs should be using something like this. The iGel. So the iGel device is hands down. It's a fantastic device. So the iGel Airway, iGel, IGEL. Yep, just shove that bad boy in. It works great. So if you ever have an opportunity to mess with one, do it. You can put that thing in there. You can put that thing in there, and then you can almost pick up somebody with it. I mean, once it's in there, it's in. So there are some complications to the King LT airway. Laryngospasm being one, we talked about that. Vomiting and possible hypoventilation may occur. Trauma also, we talked. Ty mentioned that, and it also results from, or trauma can result from improper insertion techniques. Ventilation may be difficult if the pharyngeal balloon pushes the epiglottis over the glottic opening, so you got to watch out for that. Some insertion techniques: the patient's height, weight will determine the size of the airway. So make sure you know those numbers. You got some sort of writing on it that's going to help you. Some sort of remembering device. So there are some steps in your book to show you how to insert it. It's going to be skill drill 11-12, if you're so inclined, and you should be. So up next, we're going to talk about the laryngeal mask airway, or LMAs. It's well, yeah. That sorry, I see Ty talking about tourniquets up there. Well, that's because civilian EMS is so far behind. uh, at least in our state. At times. At times. It's getting better, though. It's getting better. But that's because paramedics should be getting better. And the ALS providers, let's say that. ALS providers should be getting better now that we have AEMTs in the mix. You should be getting better. LMAs are really good as well. It's designed to provide some like a conduit from the glottic opening to the ventilation device. So there are many advantages compared with ventilating the unprotected airway with a mask. It provides better oxygenation. Ventilation does not require the continual maintenance of a mask seal. Insertion is easier, and there's less risk of soft tissue, vocal cord damage, tracheal wall, or dental trauma. And it provides protection from upper airway secretions as well. Uh, that's why LMAs are still used in surgical procedures. There's a lot less damage to be had. They're easy to insert and so on and so forth. They're great things to use. They work very well. Now it's some things that it's not going to do. It's not going to provide as much protection against aspiration as does the ET tube. Uh, it may actually increase the risk of aspiration in patients that regurgitate. Should not be considered a primary airway for emergency patients at all. And then there's some indications and contraindications for the LMA. It should be considered as only when a patient can't be intubated, and then it's less effective in obese patients, and should not be used in patients with morbid obesity. And why is that? Why is that, you think? Because a lot of those patients are very anterior. Their structures are different, as well as the ineffective ventilations of patients. It's going to require higher pulmonary pressures, and it's not going to be able to keep up with that as well, just because of the way it's shaped, the way it's formed, and the way it fits in there. Closure of the airway possible, like if you were to insert it incorrectly. Is that what you mean? It's pretty hard to insert incorrectly. Yeah, it can be. Yeah, it's not so much that, it's just it doesn't create a good seal. It's not going to create a good seal. So some complications of using the LMA. Uh, the LMA should be used only in patients who are fasting, because it can make you regurgitate. Hypoventilation, who require high ventilatory pressures, can occur. Hypoventilation. And then patients should be monitored for evidence of upper airway swelling as well. There it is. Look at there. There's the eye gel. Great little device there. iGel supraglottic airway. It's inserted in a manner used kind of like the LMA is. It's designed to create a non-inflatable anatomic seal of the pharyngeal, laryngeal, and paralaryngeal structures. Uh, it's a common rescue airway device. We don't see them a lot around here. Very rarely do you see them anywhere around here. I don't think I've seen any down here at all, actually. So it features an integral bite block because it's very thick, very thick. Uh, you carry them where? On the military side? I know on the military side we carried them. but they are awesome. They're great to use. They're color coded. Proximal hook ring indicates the size of the gel, the eye gel. Oh yeah, yeah. Yep. Alabama's advanced in a lot of things. There is the Cobra. You don't see a whole lot of those anymore either. So if they're recommended in patients who aren't at risk for vomiting, so that's a good one. Uh, Contraindications: risk of aspiration or massive trauma to the oral cavity. Don't use it. Uh, Complications of the Cobra are going to be if the Cobra is not inserted far enough, inflation of the cuff may cause the tongue to protrude out the mouth. It'll push the tongue right out. And you got to make sure you have the proper size as well. There's some techniques on insertion. Relatively easy. And here's a favorite down here, the Combi tube. Uh, it's a multi-lumen airway device. The Combi tube, it can be inserted blindly into the airway. It's a reasonable alternative to the ET tube, and then proven to secure the airway and allow better ventilation from a bag valve mask as well. That's our, if you can't get the tube, go with the Combi tube. As you can see there, sometimes if you get lucky, you can get the spot. You can get right into the lungs. If you don't get lucky, then you're covered as well. So the tube can be used for ventilation, whether it's inserted into the esophagus or the trachea, because it contains two lumens. It accommodates any ventilation device. Um, Effective ventilation is possible when the tube enters the esophagus or the trachea. Just like I said, the jaw thrust maneuver should easily elevate any ventilatory difficulty that occurs in the epiglottis uh, if the epiglottis obstructs the airway. Then it requires strict attention and good assessment skills in order to get it right. The multi-lumen airways are usually considered temporary airways and should be replaced as soon as possible. So when they get in the hospital, they need to replace it. So some indications and contraindications of the Combi tube. It's indicated for the airway management of overresponsive apneic patients with no gag reflex and whom an ET tube is not possible or has failed. It cannot be used in pediatric patients younger than 16 years of age. And then it should be used only for patients between 5 and 7 feet. I think I would probably look at that more than anything. Because you got some big kids out there sometimes. Should not be used in patients also with a known pathologic condition of the esophagus. So if there's an issue with the esophagus itself. Some complications of the Combi tube. Unrecognized displacement of the tube into the esophagus. And you have to use a rigorous confirmation protocol following insertion of the device. And then laryngospasm, vomiting, just like with the others, you can have issues with as well. Uh, Trauma to the pharynx or the esophagus may result from improper insertion of technique. So practice, practice, practice. That's the easiest way to tell you to get it right. There's some insertion techniques. So some stuff, foreign body, airway obstruction. Foreign body that completely blocks the airway is a true emergency, right? It will result in death if it's not treated immediately. In an adult, usually occurs during a meal. In a child, it occurs while eating, playing with small toys, crawling around the house, just generally doing kid stuff. And in unresponsive patients, the most common obstruction is the tongue itself. Recognition of this, early recognition, is going to be very important so that you can provide emergency medical care effectively. And then obstruction of a foreign body can result in mild airway obstruction or a severe airway obstruction. Uh, you got to take great care to prevent a mild airway obstruction becoming a severe airway obstruction. You don't want to push anything further. So, with a mild obstruction, the patient can cough forcefully, although you may hear wheezing in between coughs because of the object caught in there. You got to continue to monitor that patient closely and encourage the patient to continue coughing. Maybe it'll dislodge. Attempts to remove the object manually could force the object further down. That's why you use the McGill forceps, man. So also with poor oxygen exchange, the patient has a weak and effective cough, and it may increase difficulty breathing, stridor, and cyanosis, the blue tinge, right? So one sure sign of severe obstruction is the sudden inability to speak or cough immediately after eating. So this, right, the person may grasp or clutch his throat. Uh, Complete and thorough patient assessment is going to be the key to the win on that one. And if patient's found unresponsive and does not appear breathing, you should begin CPR, right, with high quality chest compressions. And what can we do to what can we hook up to a monitor if we have the availability to do so to make sure that we're doing high quality chest compressions? What can we hook up? Anybody? ET CO2? End-tidal CO2. Capnography. Hit up that capnography. That capnometer. That's right. Do it. Gold standard. All right, ladies and gents. That's it for that one. Get off my screen. All right, what we got here? So, do we have any questions about anything we went over tonight? Now's the time to ask. Okay. If we have no questions, then I'm going to look at something right quick in here. Do we have any questions about any past stuff or anything else? Any navigate questions or anything like that? I'm moving stuff around. What are we asking? If we have any questions, if you have any questions about anything we went over or any assignments or anything like that. Oh my goodness. No. So if you look on there on the directions, each one of those. Hold on, I'm opening it up now. No, I have not given the code yet. You are not getting away that easy. Hold on, I'm opening up the discussion. All right, so the patient assessment scenario. I'm having trouble breathing. You are called to a resident of a 67-year-old man who complains of respiratory difficulty. You arrive at a safe scene to find the patient sitting in a tripod position in a living room chair. He is only able to speak three or four words without catching his breath. What do we call that? Does anybody remember what we call that? Using your textbook, internet resources, and reference books that you have available, research each element of the patient's condition. So research the fever, and then separately research the abdominal ascites, and then separately research productive cough with brown sputum. And these are separated for a reason. And these, you have to look at these for a reason. There's a reason why we want you to research each individual one, right? So not all findings are found simultaneously in the patient. So look at each one individually and determine what each might mean to you as an EMT if you are called to care for that patient. So say you talk about fever. All right, so you know that fever can be caused by this and this. Abdominal ascites. What causes that? What are some indicators of abdominal ascites? And this is how we. So when you take all of these things in one patient and you start looking, then at that point you're going to start making decisions as you go down and decide, this is what this patient may have. This is what it had. I know he takes albuterol. He takes albuterol for what? I know he takes Atrovent. He takes Atrovent for what reason? What are some of the reasons he would take it? He's got crackles in bilateral lower lobes. What does that mean when he has crackles in bilateral lower lobes? What does that mean? Scattered wheezes. What does that mean? And we take all those, and you're taking all that from that assessment, and you're individually, and then you put it all together, and you're like, he's likely to have this type of injury or illness. Yeah. It's not what I want. It's what the patient wants. So that patient's a mess. And y'all picked it. Y'all picked this punishment. That's what's crazy. assignment wise, where did I miss one? So discussion from chapter 10, you're just wanting us to write about how we would treat. Yes. So that I just want you to, just like it says in there, research each element of the patient condition below. Not all findings simultaneously. Look at each one individually and determine what it might mean to you. So write down each one, what it might mean to you. No, you picked it as a group. It's a group. Hey, y'all. Hey, win as a team, you fail as a team. This is a team. You win as a team, you fail as a team. This is number 3. That's what I said. The majority of you picked number 3. This was number 3. Neither here nor there. Uh, does that kind of explain what I'm kind of looking for as far as that goes? Awesome. You are very welcome. Hold on, I'm looking up the number. Or yeah, the 4-digit code. I keep it in a secret binder. Locked away. What are we on? Chapter 11? And also, Torrance, I will not forget, if you're still on here, Torrance, I will not forget about the 5 points to your lowest passing grade, your 5 bonus points. So I'm not going to forget about that. You gave it a good shot. Nobody else would, and you did it. I don't know, Rob, if you missed it. So Torrance got on, and I wanted an actual demonstration of what Kussmaul respirations sounded like. And after waiting for about 2 or 3 minutes for somebody to speak up, she actually cut her mic on and did the sound for the Kussmaul respirations. So she got 5 points added to one of her test grades. That's what I may do for one of the assignments, is have y'all recreate what crackle sounds like, what Kussmaul respiration sounds like, what, just go down what Strider sounds like, what Ronkai sounds like, what I may just have y'all go down the list and send me a sound bite of what each one sounds like, because I know y'all can talk. Y'all can record it and send it. I think that'd be a pretty good assignment. I'm trying to find. Let me get back to the. I'm getting back to the chapter. All right. Do we have any questions about anything in the chapter? As you can see on the chapter, there is a lot. There's a lot in it as far as on chapter 11. There's a lot in it as far as help. Like there's a lot of extra resources in there. And each one of y'all, have y'all been going over your task sheets or your skills sheets for AEMT? If you don't know how to find them, you can actually get on the NREMT website, or you can Google NREMT AMT skills sheets, and it'll send you to a site that's got all of them down there. I sent them to you in an email as well, and I think that's probably going to be the golden way, because that come from the NREMT website themselves or itself. So I would definitely make sure I'm going over those, because soon enough here I'm gonna start calling folks out, and we're gonna start going over them one by one. Your boot camp is going to revolve around your success at doing that and IV skills and everything else. You do not want to show up to boot camp and that be the first time that you've ever looked at any of those sheets or anything else. It's going to put you behind if you already don't know what you're talking about when you come in the door. So practice on your dogs, practice on your kids, practice on the husband, the wife, the boyfriend, the girlfriend. Practice. If you're a lonely person, you're at the house, practice on a pillow or a neighbor, or something like a doll or a cat. If you're a lonely person that has nobody, practice on one of your cats. I'm sure you would, Cole. That would be a combative patient. I guess I can't find it for whatever reason. The email I sent you guys. There it is. Got one. Holy cow, that's very small. I can't read that. All right, so if you're looking at your patient assessment trauma, all right, so the very first thing you're going to do upon coming in, they're going to tell you, they're going to say, hey, we got a patient. 65 years of age, fell off a ladder, says that his back hurts, blah 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 blah. That this is your patient. Go. The very first thing you're gonna do is what? Very first thing you do. BSI scene safe. Verbalize it. Verbalize means speak with your mouth that you're taking appropriate PPE precautions. Okay? Depending on what happened, they may even ask that, what would be your BSI precautions for that? So you would say, depending on what the call is, you would give that. Gown, glove, goggles. If it were like a disease person with a trauma patient, you may have, depending if is there a lot of blood, blah blah blah, then whatever you're going to wear. All right, so the very next thing is going to be what? The very next section is going to be what? Nope. Slow down. There you go. Scene size up. So verbalize PPE precautions and then scene size up. So you got to determine, is the scene safe? Okay? Is the scene safe? And you're then we're getting closer, Hannah. Uh, you're going to determine the MOI or the NOI, right? The mechanism of injury. Okay. After you determine the mechanism of injury, yep, you're going to determine how many patients do I have. All right. So let's go back. So you're the determine the scene situation is safe. So what you say, you literally say it. Um, all right. Next, I'm gonna complete my scene size up. My scene size up is going to consist of is the situation safe? Is the scene safe? I'm looking out the window, or I'm looking as I'm doing my windshield size up. My windshield size up. What do I see? Do I see any dogs? Do I see any hazards in my way? Do I see, say it. And then they'll tell you yay or nay. They'll say the scene is safe. And then you say, all right, I'm trying to determine my mechanism of injury from listening to the dispatch call. The 65-year-old man fell off of a ladder. So I'm assuming that my mechanism of injury is going to be from a ladder fall. And then they'll shake their head or whatever, or maybe they won't say anything at all. Then from there, like, I'm going to look around. Is this my only patient, or how many patients do I have? Um, they're going to tell you, and you say, at this point in time, I'm going to request additional help if it is necessary. They're going to say, do you feel like it's necessary to have additional help? And if they tell you you have a partner or not, or if you think you can handle that patient because it's an AEMT patient, then you say yay or nay. You give that, and then next you're going to say, after you say additional help, I'm going to consider stabilization of the spine. So at this point, now you're at the patient. So everything up until this point, you're walking towards the patient. Okay? Now you're going to consider stabilization of the spine. You can say, I'm going to have my partners take C-spine precautions, and then they'll say yay or nay. And then from there, now you're at the next session, the next section. So the next section is what? What is the next section? Slow down. The next section is going to be your primary assessment and resuscitation. Don't just skip into ABC because you're missing out on a few things. So this is when Hannah was right on point. So at the right after stabilization, you're going to move into your primary assessment and resuscitation. So right after that, Hannah, go back over what you were saying. So at this point, you're going to verbalize what? One more back. You're going to verbalize general impression of the patient. So you're sick or not sick. Is this patient sick or not sick? And from looking at him, he's fallen, what have you. Is he alert and oriented? So is this patient sick or not sick? And then you're going to determine at that point, like you're on, responsiveness and level of consciousness. All right, I come up and I speak to my patient. Hi, how are you? And the evaluator is going to say, he is flailing around like a fish. Or he's going to say, hey, I'm doing good, blah, blah, blah. Or what have you. Or he's going to be unresponsive. Then you're going to ask, or you're going to see, determine chief complaint, or you're going to look for apparent life threats. All right, now I'm looking for apparent life threats. Do I see any? And they're going to say, so name off some apparent life threats. Does he seem to be in obvious distress? Obvious respiratory distress or respiratory failure? Does he seem to be in some sort of cardiac event? Do I see heavy bleeding? Heavy bleeding being a big one. Okay? So, with brain injury, there's nothing you can do about that, right? As far as brain injury, you can't. As far as the brain injury, you can't stabilize that immediately. That'd be something else. Hold on, slow down. Priapisms later on. All right, so you're just looking for apparent life threats at this point, things that you can mitigate, right there, and bring that patient back, right, or save that patient immediately. So next, you're going to go down, you're going to say airway, and you're going to open assess the airway. All right, I'm checking my airway. Is my airway open and patent? Or, open, patent, equal bilateral breathing. Is my patient breathing? Yes. Is the airway open? Yes. If they say no, then you're going to say okay, and you're going to do an oral adjunct or you're going to do some sort of oral adjunct or a nasal pharyngeal. How are you going to measure? That's okay. That's why we're going to go over this over and over. We're going to go over this over and over again to get it right. All right, so you're going to open assess the airway. You're actually going to look, is my airway open, yay or nay? They'll say yes or no. If he says no, your patient not breathing, then you're going to pick one of your oral adjuncts and you're going to measure it. Yep, from earlobe to jaw to measure, or from lip, from the lip, right? Lip to jaw or lip to earlobe. Why wouldn't you go to the king? Because we're BLS before you ALS. All right, so we're going with speed here. So at this point, or if you do have an adjunct and you do have that opportunity to do so, then you can. If you have the opportunity to do so, then they may ask you to go more advanced. And you may, if you have that opportunity to do so, you can. All right, so breathing. Next, you're going to assess breathing. So at this point, you're not assessing breathing in the fact that you're talking about 60 breaths a minute, 50 breaths a minute, 40 breaths a minute. You're assessing breathing to the point of, are they breathing? Are they breathing? Yes or no? Is it adequate ventilations? Do I see equal chest rise and fall? Yes or no? Paradoxal movements. I'm looking for paradoxal movements. I'm looking for inadequate chest rise and fall. I'm looking for, start mentioning or start thinking about things like that. And they're going to say yes or no. If they say no, then you're going to administer oxygen, and they're going to tell you they're going to manage it says next, manage the injury or compromised breathing ventilation. So at that point, you're going to figure out, do I need to BVM this patient, or are we going to have to move on to something else to get this airway started? All right, from there, we're going to talk about circulation. So circulation, you're checking a pulse. You're not checking to see if their pulse is at 60 or 100 or 120 or 150. You're not checking for that. This initial primary assessment, you're going to check your pulses, and you're going to say, does he have a pulse? If he's conscious, you'll do radials. If he's unconscious or she's unconscious, you'll do carotid, right? Do they have a pulse? That's what you're looking for. Now, if they're talking to you and everything, then you're good to go, right? You're going to assess the skin color, temperature, and condition real quick. And then you're going to assess and control bleeding if there's any bleeding that's happening, heavy bleeding, life-threatening bleeding. You're going to control that. And then initiate shock management. How do we initiate shock management? Keep the patient warm, right? Keep the patient warm. So at this point, we're going to identify the priority of the patient. Are we going to stay and play, or are we going to load and go? And then you're going to also calculate your GCS. Like I told you the other day, I want you to tell me how to calculate your GCS. I'm going to give you scenarios for calculating GCS. It may be in a discussion question. It may be an assignment where I got a list of things. You're going to give me the GCS. Okay? We're going to learn GCS. That's very important. Glasgow Coma Scale. Start practicing it. Look it up online. Look it up on YouTube. And start getting it in your head, okay? Up next, once we've passed that portion and we've mitigated that portion, mitigated it, then we'll get into the history taking. Okay? You'll obtain or direct assistance to obtain baseline vital signs, and they may say, what vital signs do you want? You need to know what to list. Okay? So look up those list of vital signs, say these things out loud, practice it, practice it, practice it. And then you're going to attempt to attain a sample history. Okay? And then from there, you'll do your secondary assessment. We're not going to get into that tonight because we are over time. So secondary assessment, we're going to break it down like a fraction. I'm going to bring a dummy, or I'm going to look at a dummy or something like that, and we're going to start from the head, massaging the head and everything, all the way down to the feet. I feel a pulse, I mark it, blah, blah, blah. So we're going to do that, and we're going to break it down like a fraction like that. Well, wouldn't have to. I got a picture right here. All right. So the number for tonight. Your number for tonight is 8429. That's 8429. 8429. And I typed it and nothing happened. Eight, 4, 2, 9. All right. So I want to thank for everybody for being here. We had a pretty good turnout today. I really appreciate it. If you have any questions, once again, let me know, and I will help you out in any way that I can. At this point in time, I'm going to stop recording.